With Dr. Hoffman, we are at quorum. So welcome everyone to our DUR board on February. Happy New Year. So sad we missed you last month, and welcome back to the February meeting. As if you remember for our meeting today, if you are dialing in via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute their device and via Google Meet. DUR board member, please reserve the question until the end of the presentation or ask in the Google Meet chat. Public comment, if you would like to provide public comment. A conflict of interest must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not member of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you very much. And Dr. Kenyon, I will leave it to you.
Good morning. Welcome, everyone. We will call this meeting to order. We have a quorum. So we will move ahead with today's meeting. Noon, any other housekeeping that we need to take care of this morning? I think you're muted.
My apology. Dr. Hancock, I'm not sure if he's on this morning. Dr. Kyle Turner has come to finish his term with our DUR board, and we are having a new board member, Dr. Kobe Hancock. He also a pharmacist at the Utah Cancer Center. Dr. Hancock, if you are on, would you like to introduce yourself to the board? He might not be on this morning. If not, I think Jen do have some housekeeping item as well.
Hi, good morning, everyone. It's been a little while since I've presented here. Thanks for the opportunity to share for a few minutes. We do have some relevant updates affecting the Medicaid program and specifically the pharmacy program that I did want to share with you today. And it should take 5, hopefully less than 10 minutes, but there is some content that's important for us to go through. The first piece is notable events around Medicaid unwinding. As you know, we've been in our continuous enrollment of our Medicaid population through the duration of the public health emergency, which has now been almost 3 years. And we are beginning unwinding activities, and there are events that are happening our Medicaid members that I wanted to share with you to make sure you're in the aware of it and also aware of how this is affecting our Medicaid program. So we have over 520,000 Utahns enrolled in Medicaid right now. And so a sizable number have enrolled in the program and then been maintained on the program through the duration of this public health emergency. The Consolidated Appropriations Act actually decoupled what was the public health emergency and the unwinding activities. For some time, we've believed that there would be a 60-day notice, and with that 60-day notice, there would be the end of the PHE, and we would actually begin our Medicaid unwinding. But that Consolidated Appropriations Act decoupled that and did announce an unwinding date of April 1st. And so I'd like to actually walk through what these events are and how they affect our population. I'll try to move quickly through this timeline. If you see on this timeline graph, 12/29 was when the Consolidated Appropriations Act was signed into law by President Biden, and it did effectively note the end of our continuous eligibility requirements starting on April 1st, 2023. It also did something else that's notable. It mandated 12 months of continuous enrollment for children on Medicaid. So that will also go into effect on January 1st, but that is different than our unwinding. But I did want to throw that in there because that was a notable difference in what will happen with our policy with regard to enrollment of children in the Medicaid program. But as we kick off our unwinding activities, our teams have been working over a year on preparing for this work. And it is important that on February 15th, the Medicaid team will be submitting our initial documentation to CMS that will really kick off this unwinding and say our systems are ready, our data is ready, and our program is ready to engage in this. DWS, so the Department of Workforce Services that conducts our eligibility reviews, will actually get and begin their first round of reviews on March 1st. We actually have 2 months. So DWS takes 2 months. They get an eligibility list and they have 2 months that they review that documentation. And it is on April 30th when our first closures will occur. And so this is new and this is different. And people have been asking a long time about when this is coming, and it will have an impact. I have many dates here on this document. For the sake of time, I will go pretty quickly, but just to note that on March 31st, we will drop from our enhanced funding of 6.2% that we've had from the federal government to maintain this continuous eligibility enrollment, and we will drop down to 5%. And you can see that subsequent decline every quarter throughout the remainder of 2023. The updates I'd like to share that may affect you if you are working in the community and engaging with Medicaid members is, first of all, the general notice is being mailed out right now. So over 500,000 Utahns are getting a notice that is letting them know that the end of the continuous enrollment requirement is happening. Our phone lines already popped up on Monday, and the letters continue to be mailed throughout this week. There are 2 messages that we are passing along to our members. One is update your address. We can't send you letters. We can't contact you. You can't know what your review date is if we don't have a correct address on file. So that has been our message for the last year. It continues to be our message now. Update your address so that we can contact you. The second is know your review date. So we have a year to unwind our eligibility. So a person might be very anxious and think, it's unwinding. Do I lose my eligibility right away? No, your eligibility review could occur anytime over the next 12 months. And we've actually have a strategy around who we're reviewing when. But it's really important that members know when their review date is. So there is a case, My Case, which is our eligibility. The member can log into My Case. They can get lots of their member information there, but it's also where their review date is. And after this Saturday, their eligibility date will actually be, their review date will actually be found on My Case. And I can throw these hyperlinks in if anyone's interested. The other things is that we have a very comprehensive PHE unwinding webpage that contains a whole host of materials. It includes our provider communication, our member communication, all of our unwinding plans, but it will also contain important data that is all of our CMS data we have to report. We have put in a public-facing dashboard. So this is the members that are reviewed, their disposition as they transition to Marketplace or CHIP or stay on the Medicaid program. It talks about call volume and call wait times. So there's really important metrics we're required to submit to CMS, but are also legislatively required to report on. That data dashboard will be loaded with live data next week. And then I mentioned these here. Some of this was from my ACO meeting yesterday, so it's not relevant to our meeting today. But another piece with this is that there has been a formal announcement of the end of the public health emergency as well. So I mentioned that they are decoupled, and that is true. We will begin our unwinding activities, and that is distinctly different than the public health emergency now. but there is a formal end to our public health emergency that we've been in now for 3 years. That date is May 11th. So more to come on this, but we will begin changes. We've had numerous flexibilities in place due to the public health emergency. These flexibilities are noted on our Unwinding webpage, and what those changes look like are also noted there as well. So just a quick stop on that, Noon. I know I'm taking up too much time already, but I did want to touch on one additional piece, and this is going to be a blast of information here. But there was a legislative update that's important to note because it does affect the Medicaid program. And this is a very lengthy document which really outlines the provisions of an important bill that does have immediate impact on our Medicaid members. And the title of this is Transgender Medical Treatments and Procedures Amendments. This was put through our legislature as SB 16 and signed into law by Governor Cox on January 28th. It does have an immediate effective date. So there is comprehensive outline of the work that this impacts, but let me just highlight some of these changes quickly and the impacts on pharmacy policy specifically. So if you look here at our requirement on the left, what this effectively does, it creates policy on the treatment of gender dysphoria in individuals who are less than 18 years of age. And as of January 28th, 2023, healthcare providers cannot provide hormonal transgender treatments to minor patients diagnosed with gender dysphoria after January 28th. It does note, and it has been put in Utah code already, that healthcare providers can continue to prescribe hormonal treatments to minors who have been diagnosed before January 28th, 2023. So this is a little bit different policy than what we've had in the past. What this means for us as a program, I did just read the law to you, but what it means that we will update our prior authorization criteria for our Medicaid program, both fee-for-service as well as ACOs, to recognize that minors who were diagnosed with gender dysphoria prior to January 28th and have been treated by the diagnosing provider for at least 6 months can receive hormonal treatment with either testosterone-like products or estrogen-like products. And I'm just, for the sake of time, going to say this also applies to puberty-blocking therapy or gonadotropin-releasing hormones. So what the law essentially does is if a minor was diagnosed prior to January 28th, and they've been in treatment with that same provider for at least 6 months, they can receive hormonal therapy or puberty blocking products. If either of these were not met, if the minor was diagnosed after January 28th, our criteria will not allow, state law will not allow the member to receive these treatments that are paid for under the Medicaid program. Additionally, it's also important to note that the date of diagnosis needs to be before January 28th. If there is care with a different provider that occurs after that start date, that is before January 28th, that care needs to be for a minimum of 6 months before the prescribing of either of these classes of drugs can occur. Now, there's a lot here, and I'm sorry I didn't consolidate it for us, but I did want to walk through, and we can bring this back to you later, that there are additional requirements that will be layered in on July 1st, as well as January 1st, 2024. And we will review these with you in future meetings. So Noon, let's put these on the agenda to actually dedicate a good chunk of time to do this. What this means today for Medicaid members is that we will be posting our criteria for both minors as well as adults. It will actually be for hormonal therapy, it will be the same criteria for adults as well as minors, with those designations called out in minors around the date of diagnosis and the duration of care for a with a provider. With puberty blocker therapy, we do not have a prior authorization in place right now for members for these products. That is drafted, and that will be posted on our website very soon, and our systems will be programmed to require a diagnosis code as well as evidence, if it is used for gender dysphoria, that there was a date of diagnosis prior to January 28th, 2023. There is also another important step I'd like to share, and I'll just take it off the screen because of this document having so much text on it, is that this law also directs the Department of Health and Human Services to conduct a systematic review of the literature and convene a group of individuals that are experts in the field, but also represent institutions throughout the Valley that would be able to assess the literature as it's done a systematic review and that review is completed. And then there is a group that will be convened to evaluate this literature and create recommendations and a report that will be submitted to the legislature in the fall. Dr. Michelle Hoffman will be leading this group. We will be asking the University of Utah DRRC, who does our reviews for both our DUR and P&T program, to conduct this review for us. So there is more coming on that as well. But that is an important piece, and the moratorium will stay in place until this review is completed and the recommendations can be put forth to the legislature. Dr. Hoffman, is there anything else you'd like me to add or anything you feel is relevant at this point?
I think it's important to note the certification requirement that's being developed by the Department of Occupational and Professional Licensing, and that will be a requirement for all prescribers beginning on June 30th or July 1st. Of this year. So I actually have a hope for a more accelerated timeline on the evidence review, because that should inform the certification in some ways. We were not given a timeline by the legislature on the systematic review, only on the requirement for the certification program to be established. And so, yeah, we've got a lot of work ahead. Thank you.
Yeah. And we will bring this back as our prior authorization information is updated. We will bring this back to our next meeting. So there is transparency and visibility on that. Very last note is that we do have an active recruitment for a full-time medical director for the Medicaid program. We're looking forward to this. The medical director will report to me and have a broad oversight of the work that we do in the agency. So we're looking forward to that as well. We already have a couple great applicants who've applied. So anyway, thanks for the time today. And if there are any questions, I can take a quick question or two.
For some of us, it's best we keep our mouth shut.
Yeah, that's fine. Yep.
Okay.
Okay, thank you. I'm happy to take any questions offline as well. So if you'd like to send any questions, happy to do that. I know there was a lot of material that was covered quite quickly. I'll put the unwinding links into the chat, as well as the link to the bill itself, although it is now in statute. So I'll include those in the chat for documentation of the minutes, as well as your reference. Thank you.
I'm going to assume that's all the housekeeping, because that's all I can handle right now. So with that, you all should have received a copy of the minutes. Hopefully everyone's reviewed them. Any comments, changes that need to be made or brought to the attention of the state? All right, not hearing any. Do we have a motion to approve the minutes?
Morning,
Move
Eric. I'll
approval.
move we approve the minutes.
Second.
Okay, we have a motion and a second. All in favor?
Aye.
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 Okay, moving on. I am going to apologize. I do need to leave just before 8 o'clock. My company has sent me back for remedial education, and they get upset when I'm not in my seat. So I will, just before 8, turn this back to Noon to kind of fulfill my role for the rest of the meeting. But Noon, we will turn the review over to you now.
All right, give me 1 second. Right. So we would like to go over the LYBALVI, or it's a combination of olanzapine and samidorphan. The agenda will go over prescribing information, clinical study, current policy, utilization, a look at other state policy, and recommendation. LYBALVI is a combination of olanzapine, which is an atypical antipsychotic, and samidorphan, which is an opioid antagonist. It is indicated for schizophrenia and bipolar I disorder in adult. It can be used as monotherapy or as an adjunct to lithium or valproate for acute treatment of manic or mixed episode in bipolar I, or used as maintenance monotherapy. For doses, it is for schizophrenia, it's recommended to initiate at 5 milligram, 10 milligram, and can be adjusted weekly based on 5 milligram, the component of olanzapine, and depending upon clinical response and tolerability, maximum is 20 milligram plus 10 milligrams a day. For bipolar, initiate at 5 milligram, 10 milligram, or 10 milligram daily, and can be adjusted weekly of 5 milligram of olanzapine component, depending upon clinical response, maximum also at 20 milligram and 10 milligram daily. Warning, they share the similar warning to the olanzapine, such as increasing mortality in elderly patients with dementia-related psychosis, neuroleptic Maclellan syndrome, drug reaction with eosinophilia, and systemic symptom, metabolic change, tardive dyskinesia, orthostatic hypotension, and syncope, fall, leukopenia, neutropenia, and dysphagia, seizure. And the LYBALVI also have a severe opioid withdrawal in patients who are physically dependent on opioid and vulnerability to life-threatening opioid overdose. They have some contraindication to patients who are using opioid. They recommended to delay LYBALVI initiation for at least 7 days after the last use of short-acting opioid and 14 days after the last use of long-acting opioid. In an emergency situation, opioid should be administered by properly trained individual. The patient should properly monitor for cardiopulmonary resuscitation. In a non-emergency situation, recommended to discontinue LYBALVI at least 5 days before opioid and start olanzapine or another antipsychotic if needed. And it's contraindicated to patients who are undergoing acute opioid withdrawal. The LYBALVI have drug interactions similar to olanzapine drug interaction, such as CYP1A2 inhibitor and inducer, CYP2D6 inhibitor, anticholinergic drugs, and they have a drug interaction with strong CYP3A4 inducer that olanzapine doesn't have. For the clinical study, study 1 is the study the efficacy of LYBALVI in the treatment of schizophrenia in adult, which is based upon the adequate and well-controlled study of olanzapine. It's a 4-week randomized double-blind placebo and active control olanzapine study. They have inclusion criteria of patient who is 18 to 70 years of age, have PMI of 18 to 40, have a positive and negative syndrome scale of more than or equal to 80, have a score of more than 4 on at least 3 of the selected positive scale item, has the impression severity score of more than 4 or equal 4. The primary endpoint of the study is to study the change from the baseline in DEPENDS total score at week number 4. Looking at the result, we can see that is the LUBAVI and the olanzapine shares similar score in the placebo subject difference of the total span score from the week number 4 at LUBAVI as is minus 6.4 and the olanzapine is minus 5.3. The result of the clinical study is that is compared with the patient on the placebo, it is statistical significant improvement in the change from baseline in the PANSS total score at week 4 were observed in the patient treated with the LUBAVI. The study also concluded that the inclusion of samidorphan in LUBAVI does not appear to negatively impact the antipsychotic efficacy of olanzapine. The second study was looking at the weight change in patients with psychophenia. It's a 24-week randomized 1-to-1 of LUBAVI and the olanzapine. This is at the initiation of both medication. The inclusion criteria is the patient 18 to 55 years of age, has a PMI of 18 to 30, has a positive and negative syndrome scale of 50 to 90, has the impression severity score of less than or equal to 4, have a symptom suitable for outpatient treatment. They excluded the patient with diabetes. The primary endpoint is looking at the percent change from baseline in body weight and the proportion of patients who gain more than or equal to 10% of body weight as week 24. This is the result of the clinical study. Looking at the mean percentage change from the baseline in the body weight, the LUBAVI is 4.2%, while the olanzapine has more than that, is 6.6%. The difference between those two is minus 2.4%. And for the percentage of patients who gain in more than 10% of body weight, LUBAVI has 17.8% of the total population gaining more than 10% of body weight. The olanzapine has 29.8%. The conclusion of the study is the treatment with the LUBAVI were associated with statistical significant reduction in weight gain versus the olanzapine. LUBAVI treatment has smaller proportion of patients who gain more than or equal than 10% body weight. The weight is a reminder that the weight effect of switching from olanzapine to LUBAVI is unknown, as the study was designed for the medication to be compared at the initiation. For the indication of the bipolar, the efficacy of LUBAVI in the treatment for adults with the bipolar disorder has been established based on adequate and well-controlled study of the olanzapine. There's no set design for the LUBAVI on bipolar. As Utah current policy is LUBAVI right now is a non-refer product. To obtain the medication, the provider have to submit the medication coverage exception PA with the requirement of trying a failure or intolerant or contraindicated to only one referred product. For utilization, we're looking utilization for LUBAVI since June of 2021 is when the medication was first approved until the most recent data of February 8, 2023, have a total of 51 PA. That's what review. We approved 27 PA and denied 15, and the rest is other reason, not requirement or patient is not eligible for Medicaid. Looking at the claim, we have a total of 746 claim of 127 unique patient. The reason why there is a difference between the approval and the unique patient is this medication is can be obtained using DAW1 that will override the BA requirement at the point of sale as a non-refer. Looking at other state policy, North Dakota, Ohio, Oregon, and Delaware is having the LUBAVI as a non-refer. There's no additional criteria. For Mississippi and Pennsylvania, the LUBAVI is non-refer, have a restriction with no additional criteria. For Iowa, LUBAVI is a non-refer product on PDL requiring a step therapy of trying a failure of 2 other antipsychotic. For Maine, LUBAVI is a non-refer requiring a step-through therapy, try and failure of both aripiprazole and the Latuda. And then it will be approved for 3 months if the patient failed both of Abilify and Latuda. The reauth criteria is if the patient not gaining weight more than 10% of the baseline body weight. If the patient does gain more than 10%, it will be denied at reauth. For Vermont, Lybalvi is also non-refer. They have additional criteria of trying a failure of at least 3 antipsychotic, one of which must be the Abilify or Latuda. They also requiring the patient to be opioid-free for 7 days for short-acting and 14 days for long-acting opioid. West Virginia, Lybalvi is a non-refer, require patient to have positive response with olanzapine and has a good experience. However, have clinically significant weight gain that caused the disruption to treatment with olanzapine. Require patient to have tried a failure of 2 other refer antipsychotic, such as aripiprazole and ziprasidone, would have the lower potential of weight gain before the Lybalvi approval. Our recommendation is to keep the Lybalvi as a non-refer and require a clinical prior authorization. We can review the criteria in just a moment. That's concluded my presentation. If there are any questions.
All right, thank you, Noon. It appears we do have some public comment. Kenneth Berry, are you present?
Yes, I am. Can you hear me?
Yeah, great. We'll turn the time over to you. We do give you 3 minutes, and Brian Larson is our timer. So,
Okay. All right. Well, my name is Kenneth Berry. I'm a medical science director with Alkermes, and I want to thank you for the opportunity to provide information on Lybalvi. We know that schizophrenia and bipolar I disorder are serious mental illnesses requiring long-term treatment and are associated with comorbidities and decrease in life expectancy. As you heard, olanzapine, although efficacious in both disease states, has been associated with the risk of significant weight gain. Lybalvi is a combination of the olanzapine and samidorphan, an opiate receptor antagonist. It is indicated for schizophrenia and bipolar I disorder, as well as acute treatment of manic or mixed episodes as monotherapy, adjunct therapy, or maintenance monotherapy. Now, in adults, Lybalvi demonstrated antipsychotic efficacy and was associated with statistically significant less weight gain than olanzapine. Approval of Lybalvi was based on studies of olanzapine and 2 phase 3 clinical trials. Study 1, Lybalvi demonstrated statistically significant symptom improvement compared to placebo at 4 weeks, as measured by the PANSS score. Inclusion of samidorphan did not negatively impact efficacy of olanzapine. Study 2, Lybalvi demonstrated statistically significant less weight gain from baseline at week 24 compared to olanzapine. Risk of gaining that greater than 10% body weight was lower by 50% with Lybalvi relative to olanzapine at week 24. The most common AEs with Lybalvi were increase in weight, somnolence, dry mouth, and headache. No weight gain was the most common adverse reaction with Lybalvi in both pivotal trials. Now, each study was followed by 52-week studies. The longest term outcomes were after study 2. AEs reported in 61% of those patients. Most common were weight decrease, extra dose administered, headache, and weight increase. 63% of those patients completed, and approximately 6% discontinued due to AEs. Now, weight was measured, though the study was not powered to examine the changes in body weight, and conclusions cannot be drawn from this data. But in the preceding clinical trial, patients in both the olanzapine and the Lybalvi group gained weight on average. At the end of the 52-week extension study, the mean body weight difference from baseline was 0.03 of a kilogram. So Lybalvi's safety and efficacy in bipolar I disorder was based on studies of olanzapine. Lybalvi does carry with it, as you heard, black box warning with increased mortality in elderly patients with dementia-related psychosis, and is contraindicated in patients using opiates or undergoing opiate withdrawal. An opiate-free interval is needed prior to initiation. Closing, we respect that Lybalvi be made accessible to patients without coverage restrictions. Welcome any questions, and I can provide you any prescribing information that you may need on Lybalvi. I want to thank your time for today, too.
thank you. And any questions from the committee? Dr. Weinstein?
I'm just wondering if you have any data about opioid-related adverse effects or adverse events around the conversion or initiation of therapy, given the warnings.
Warnings, I mean, any adverse reactions reported during the trials?
Yes.
There was one in a trial where urinary drug screen came back and was positive for opiates, so they actually stopped LYBALVI. And then on a further examination, the patient was actually a false positive, so they reinitiated LYBALVI during studies. Patients on opiates were excluded from the studies, so very minimal information on that throughout the studies.
So that remains theoretical as far as we know.
Well, samidorphan's an opiate antagonist, so structurally it's similar to naltrexone. So you definitely do not want to be on opiates because of that binding to the mu receptor.
Thank you.
You're welcome.
I think you unmuted, Eric, Dr. Sikri.
Yes, I had a few questions regarding the studies. First, you have not done a study that there's any evidence of switching from another antipsychotic to this medication will either prevent further weight gain or cause weight loss. Is that true?
In the extension study, so in Enlighten 2, patients were on olanzapine and LYBALVI, and then they switched into the 52-week arm of the study. So in that study, the graphs, you can see the breakdown of what antipsychotics they were on before, and then when they switch over just to LYBALVI for 52 weeks, and then you can see that weight gain, which was almost negligible. That was that almost 0.06 pounds were gained over 52 weeks. So we have that data from olanzapine. Now, in the studies, some of the most common antipsychotics they were on were spiridone, Haldol, and quetiapine prior to initiating into LYBALVI, but there's no measurement of weight during that time.
Second question I had was in the majority of the studies that you did, these were basically LYBALVI was being tested more for preventative effects as opposed to people who already had a BMI greater than 30. Is that sort of in terms of place of therapy? Is that where you're really looking at this medication?
That's a great question. Actually, we have, just so you know, we have the Enlighten 1 studies, as mentioned, that was looking just at the PAN scores, but those patients had higher BMIs, all the way up to 40. So in the long-term study, the 52-week following that one, it was 1.86 kilograms. That was average weight gain throughout that study, even though it was empowered to measure it. So you saw that end. And then with the Enlighten 2, of course, minimal weight gain throughout those 52 weeks. But we also have an Enlighten early study, which was 12 weeks, that looked at younger patients early in the disease state, and they had similar results than what we saw in Enlighten 2. So we had a wide range of patients that had been initiated on LYBALVI. So different states in their disease, different places in their disease, and different BMIs. So ranging from 16 all the way to 65 years of age. So LYBALVI, basically to answer your question, LYBALVI did mitigate the weight gain in all those patients.
And in those studies, were there any clinically significant effects on metabolic parameters?
Yes, the Enlighten 2 shows, well, actually both studies, Enlighten 1 and Enlighten 2, but Enlighten 2 was designed specifically to look at metabolic factors. So the glycemic and lipid parameters were stable throughout the 52 weeks. They were flat through 52 weeks. And then you saw similar results in the Enlighten early study, which was a separate study. That one actually included bipolar patients as well. And then we have a 48-week study. So just give you an idea. So Enlighten 2 was 24 weeks, and then the extension study was 52 weeks. After that 52 weeks, patients were rolled over into a 48-week study. So we'll have those results December of this year. So answer your question, yes, there was an impact on metabolics, glycemic and lipid parameters.
So you're saying basically that they did not worsen, but they did not improve. They just were unchanged.
Unchanged, correct.
Okay.
The graphs were, if I showed you the graphs were pretty much flatlined for the 52 weeks for those parameters.
And for most of the studies, were the individuals olanzapine naive prior to the study, except for, I believe, a week-long olanzapine only run-in?
Correct. Most of them were naive to olanzapine prior to the study.
Okay, thank you.
So waist circumference, as a side note, waist circumference was also measured in the Enlighten 2 studies as well.
All right. Any other questions? All right. We will move on. Wendy Woods from Odyssey House.
Hi, thanks for having me. I don't have all the fancy data like he has, but I just have some real life information. What I've seen with my patients, I have about 8 patients on my team that I've switched to Lybalvi. A lot of our patients come out of jail on olanzapine because it's kind of a standard medication that they give in jail. My patients all suffer from serious persistent mental illness. Most of them are diagnosed with schizophrenia and bipolar. My patients are very challenging. They're all involved in the criminal justice system and they're all on Medicaid. And what we see with olanzapine in general is that they all become less agitated. Their hallucinations and delusions are decreased. But the great thing about olanzapine is that it works fast. It works very fast with these patients. And what we do know about antipsychotics is the side effects is the #1 cause that patients stop taking them. And a big thing is the weight gain. Patients don't like that. And that's very prominent in the female patients that I have. So the patients that have complained of that, I have switched over to Lybalvi, and that's kind of tapered off that weight gain that I've seen in them. And they have actually reported to me that they have noticed a decrease in their appetite and decrease in their soda intake, which is kind of an odd thing to have them notice, that they were drinking a lot of soda and that they've kind of decreased that intake. So the weight has kind of stabilized. Not a lot of weight loss, but more of a stabilization that I've noticed in them. My patients also have dual diagnosis of substance use disorder. So off-label, I have noticed that they've had decrease in their drug cravings. So that's one very significant thing that I would like to see, the open access for Lybalvi to be able to use for these patients, just kind of a
It appears that Wendy is frozen. Let's give her a moment. I've paused the timer until we get her back.
Look like we lost Wendy for a moment. Stephen had, if you are on.
Yeah. Hi, my name's Steve Hyatt. I work as a psychiatric nurse practitioner down in Blanding, Utah. And I've been with Samoa Counseling Center for 25 years and just recently switched over to Utah Navajo Health System. And, so working outpatient rural psychiatry for a long time. Anyways, been an advocate of olanzapine, except for the weight gain, and seen its utility, and certainly we know the literature has shown that it seems to rise above the other antipsychotics as far as efficacy. You know, it's interesting. You can look in the literature for the reasons why. But my experience as far as boots on the ground with LYBALVI, so it was FDA approved back in May of 2021. I think I started using it in the fall of that same year. Was really interested in what it would do as far as its mechanism of action, and it being touted to reduce weight or just to see what would happen with that. So my experience has been working primarily with SPMI, patients diagnosed with schizophrenia, also bipolar disorder, and most of the patients were not olanzapine naive before I switched them to LYBALVI. And my experience has been with LYBALVI, definitely there's been significant reduction in weight gain with a lot of those patients. So with our patients, we have a very interesting situation that we're able to do oral daily administration with a lot of our SPMI at San Juan Counseling Center. We're able to, and then we would do weights every 1 to 2 weeks and really keep track of people. And so, you know, I tried to have some healthy skepticism when I first started utilizing LYBALVI, and I was pleasantly surprised to see trends of two things that typically would happen: either significant reduction in the weight gain as it was occurring over the months, or even it seemed to be that their weight seemed to neutralize, and maybe the weight seemed to neutralize or plateau more with those individuals that you know were making some type of efforts to as far as in diet and exercise, which is difficult with the SPMI, but even with some of those that weren't, we're seeing that their weight just seemed to plateau. So I guess I'm just advocating for consideration of LYBALVI. It's definitely a great medication. Thank you. Yeah, thank you.
Thank you for all of the public comment. So this is the prioritization criteria proposal for the LYBALVI. All of the following criteria must be met with chart notes submitted for all of the requests. The patient is 18 years of age or older, have a diagnosis of either schizophrenia or bipolar 1 disorder, have a trial and failure of at least 2 refer at a typical antipsychotic medication, and one of them must be either aripiprazole or lurasidone, and providing the baseline body weight prior to starting the LYBALVI, and the attestation that the patient is not concurrently using LYBALVI with opioid. Patient must be off the short-acting opioid for at least 7 days and the long-acting opioid for 14 days. For the re-auth criteria, they have to be giving the updated note that support the continuing clinical benefit of the medication, which is the LYBALVI. Has the patient increased the body weight not more than equal up to 10% baseline body weight prior to start the LYBALVI? Has the updated body weight after starting the LYBALVI? The initial authorization will be up to 3 months, and the re-auth will be up to 1 year. The provider certification attests to that they have discussed the potential and the potential risk and the potential harm and the benefit of the antipsychotic medication with the patient, have done the routinely monitoring for antipsychotic side effect, and attest that the information provided is true and accurate to their best of knowledge and including the patient medical record. Did the board have any comment, question, discussion to the criteria? Dr. Winston?
Thank you. Just on the, okay. I think under trial and failure, I think aripiprazole, there's another P in there. I think that might be a spelling. Yeah. And this come down to patient is not concurrently using Lybalvi with opioids. I think this raises a little bit of question about which opioids are we talking about, and this could get into a lengthy discussion, but I think we mean opioid agonist therapy, right? We have a lot of patients who've been converted from chronic opioid therapy for their pain management to buprenorphine, and I don't know if I'm not aware of any investigation of any of this kind of concurrent treatment with buprenorphine, but I think it would beg the question: do we mean opioids that would include agonists as well, or would this be contraindicated? So I'd be interested in people's thoughts about that. And in the second part of that, I'm not sure why what we mean by long-acting opioids. If we mean a time-release morphine, like a Q12-hour drug, then there's no reason to make a 14-day. But if we're talking about something like methadone that has a long half-life, then we might want to have somebody off for a longer period of time. So if that's what's intended there, you might clarify that language. But I think a lot of folks in policies have mixed up the terminology and have not been clear about what's meant by short and long-acting opioids. So I'd like to know what our intention is there and just make sure we're clear. So interested in people's thoughts about buprenorphine. Any pharmacists on the call have thoughts?
I think the suggestion of allowing for partial agonists such as buprenorphine is a good suggestion, a good idea.
So should we change that to not concurrently using with opioid agonist and be specific, or should we be cautious and limit this altogether?
I mean, I think it's a good suggestion to specify opioid agonists and simplify it that way.
Okay.
And Dr. Winston, for the long-acting opioid for 14 days, we base this criteria based on the prescribing information. It will be based on the long-acting opioid on our PDL is the extended relief of the opioid, OxyContin, MS, morphine sulfate, ER. Those would be our intention when saying the long-acting opioid. But we welcome the thought and the suggestion from the board.
Yeah, that doesn't make a whole lot of sense to me. I mean, the pharmacists on can comment, but if I take a 12-hour pill this morning, and that drug's released by the end of the day, the half-life doesn't change, right? I don't need 14 days to clear that any more than I would if I took a short-acting drug. So I understand the long-acting in terms of time release, but for this purpose, I'm not sure that the patient needs to be not taking those pills, for 14 days to be clear to start, you know, a naltrexone-like drug, right? But if we want to, I mean, it's not going to hurt them to be off longer, but I don't think it's medically necessary. But if we were talking about, you know, the difficulty is we wouldn't be measuring their serum to see that they're, you know, that they're free of drug, like for something like methadone, which might hang around for somebody for a much longer period of time. So I'd be more concerned about the methadone pharmacokinetics than I would, you know, a time release opioid like oxycodone or morphine.
Do you have any comment on that, Dr. Berry from Alchemus? What a reason for that particular instruction on the PI?
Yeah, with our studies, like I said, we had excluded the opiates, and but with the research that we did, that the 14 days was what we found. Can do definitely longer days for, say, like a methadone with longer half-life. In some of the studies, preclinical studies, they had some patients that actually had some overlap, but there was no ill effects. But we have to make our recommendations towards our PI. So the PI is the 14 days. That's what's based on our research as of right now. So,
Were partial opioid agonists such as buprenorphine also excluded?
I think that was a question to the guest.
yes. Oh,
Yes.
did you hear? Yes, yeah, it was excluded. I'm sorry. I didn't know if you heard that. Yes, it was excluded.
Thank you.
With that, we changed the criteria to patient is not concurrently using LYBALVI for opioid agonists. Patient must be off short-acting opioid for at least 7 days and long-acting opioid for, I can change this into short-acting opioid agonist for at least 7 days and the long-acting opioid agonist for 14 days. If the board have a motion or any other question on the other criteria.
I think on the words opioids in that sentence, you can take the S's off. Yeah, thank you. Dr. Siegfried, do you have other thoughts?
Well, unfortunately, HB, 437 basically circumvents this entire PA. So as complicated or as well intended as this is, it's sort of in some ways a moot point. Most of the research that I've done suggests that its place in therapy, including looking at the VA monograph and other documentation, is really someone who is starting olanzapine, and it's really been, the focus has really been on more preventative effects and trying to mitigate the significant weight gain while allowing the use of olanzapine because of its efficacy. And there's no evidence that at this point people already taking olanzapine who change, at least in clinical trials, change to this product actually, maintain weight other than efficacy. But also there's no evidence of switching, the other thing I am concerned about is people switching from another antipsychotic thinking that this will prevent weight gain or cause weight loss.
Brian, you would like to give a comment?
Yeah, I just wanted to address one thing that Dr. Siegfried had mentioned is HB 437. And HB 437 applies specifically to the preferred drug list and preferred non-preferred status. It does not apply to drug-specific prior authorizations. We have precedent with an antipsychotic. Well, we have antipsychotics in children prior authorization form, but we also have one for the Abilify MySite. And so we do have precedent of drug-specific prior authorizations in psychotropic medications.
Thank you for that clarification.
Yeah, but based on those comments, I mean, there's one other area that I think would beg more research, and that is, just reflecting on the comments from one of the guest speakers in the population where there's significant opioid, substance use disorder. These combination products could be very useful for those patients who are concurrently diagnosed, but we don't have that. We don't have that data. So for eating disorders and other kinds of, substance use disorders, these products might be very useful, but I'm hoping we get the research data to support its use. If it improves compliance to therapy, treatment adherence to therapy in these complex populations, that would be very useful information to have going forward, but we don't have it at this point. But I think it could be promising if that research could be done, crossover trials or other kinds of comparison studies in those particularly vulnerable populations, which are overrepresented in the Medicaid population.
They did do one study of Lybalvi in schizophrenia with alcohol use disorder, and that was negative. However, they have not studied it in other substance use disorders that I know of to date.
Any other comment on the PA, or do we have a motion?
I move approval as amended.
Any second?
Second.
All in favor?
Aye.
Aye.
Any opposed? Any abstention? Okay, with that, the PA is moved as amended. All righty. Thank you very much. And we have the next DUR board next month on March 9. The topic will be the adult pulmonary arterial hypertension. Do you have a motion to adjourn?
I'll move we adjourn.
Thank you. Second?
Second.
All in favor?
Aye.
Any
Aye.
opposed?
Me.
Thank you very much, and have a good day. Thank you.
Thank
Have a
you.
great weekend, everyone. Bye-bye.
Thank you.